We are about to start. I hope everybody has something to eat, or has eaten, or is not hungry at least. We will have a very interesting meeting today. The menu is excellent. We will speak about drug-coated balloons today. With me are key opinion leaders in the field. I'm co-chairing this meeting together with my colleague and friend Simon Eccleshall from the UK. And we try to have this interactive, so if you have questions or remarks or criticisms or anything like that, please go to the microphones and speak up. We will, after each talk, we will have some time to discuss things. Okay. And I think I'm the first speaker and I'm about to enter here. Okay, my topic today is the evidence-based treatment with the established sirolimus and paclitaxel DCB. These are my conflicts of interest. As you know, the DCB technology is not a simple technology. We have lots of different techniques, and all these techniques, they're aiming to bring the drug that is active to the vessel wall in order that the drug is working there and is inhibiting a restenosis. This is the aim of drug-coated balloon technology. And there are different drugs, there are different coating types and different designs. For example, there is paclitaxel, biolimus and sirolimus on the balloon. There are different types of coating like matrix coating or phospholipids or nanoparticles and some other coating, and there are different excipients that support this action. As an example, we have for the hydrophilic matrix, we have sequent please. This is a balloon that is working with paclitaxel or sirolimus. There is the magic touch balloon that works with the nanolute system, which is phospholipid based. There is the Virtue balloon. This is a porous balloon where you can put the medicament through the little pores into the vessel wall. There is the Solution balloon, now under in a large clinical study where a cell adherent technology works with microreservoirs. And at the end, this is more historical, the pure crystalline coating. This is an old version of the Elotax balloon that has been covered with paclitaxel. So there's a large array of techniques and also a large array of available coated balloons. This is a somewhat outdated list of commercially available DCB. You see here mainly paclitaxel DCBs, but also sirolimus DCBs. And it is important to note that there is no class effect. You have different dosages, you have different formulations, you have different kinetics, and all this brings together a variety of actions, of efficacy, and also safety. And therefore, there is a problem when you say every DCB is the same. It's not, all are different. So we want to speak about the evidence here. DCBs have been tested in very much indications. The most common indication for DCB is the instant restenosis. This has been tested in a lot of studies. There is a lot of data there. Instant restenosis has been a class A or class 1 indication for instant restenosis. In US guidelines, this is a little bit different. We will talk about this. But instant restenosis is the most common indication for this. Small vessel disease has been tested in a couple of randomized trials. So this is also a very known indication for DCB. Then there are other indications like the high bleeding risk, because you can limit the dual antiplatelet therapy to a couple of weeks or even days if necessary. Bifurcations is a very attractive indication for DCBs, at least in a hybrid setting where you have like stent and DCB, or even DCB alone. You can simplify the intervention with DCB enormously here. And then some newer indications like large vessel disease and acute coronary syndrome. So we have, for all these indications, we have some studies and some data available. Of course, this is a sponsored session, and there's one specific DCB that is there for a long time. You see here a list of all available data for this one specific DCB. At the end, you have more than 110 studies, more than 25,000 patients, and more than 20 countries where this DCB has been tested since 2006, where Bruno Scheller published his first New England Journal paper in in-stent restenosis. And this means 20 years experience with this paclitaxel balloon, and the data in more than 2/3 of data of patients, this data comes from this balloon. So this is an enormous amount of data. When we speak about paclitaxel-coated balloons and in-stent restenosis, there has been a large meta-analysis, the Daedalus meta-analysis, which showed that drug-coated balloons are reasonably effective in treating in-stent restenosis. Of course, they are not that efficacious like DS, but you avoid the second layer of stents. But the safety on the right side, the safety is better in drug-coated balloons. In small vessel disease, we have a couple of randomized trials with paclitaxel-eluting coated balloons. You see here the Andromeda meta-analysis that has recently been published with a benefit of drug-coated balloons in this setting against drug-eluting stents. So we have here good data. And it's important to note that paclitaxel is not toxic in the setting of coronary artery disease. There has been some rumors, some studies in the periphery, but these were not well done statistically. And with all this data available, we could prove that paclitaxel has not toxicity, it's not dangerous for the patients. You see here in this meta-analysis of 26 randomized controlled trials that all endpoints, all-cause death, cardiac death, MI, and TLR are on the DCB side and not on the wrong side. So we have something like a gold standard with this balloon, this paclitaxel-coated balloon. Every new device is and will be tested against this balloon at the moment. For example, in the Transform 1 trial, we had the Magic Touch sirolimus-coated balloons in de novo disease that has been tested and failed to show non-inferiority. The Reform study tested biolumus-coated balloon in in-stent restenosis and failed too. So this is a hard competitor, as you see. But there are other balloons that showed the same efficacy, non-inferiority. For example, here another sirolimus-coated balloon in in-stent restenosis in a combined trial in 101 patients with the same in-segment late lumen loss as the paclitaxel balloon. And here de novo lesions in, again, 2 parallel trials in 140 patients with a very similar in-segment late lumen loss, and also with similar numbers for negative late lumen loss, the lumen enlargement as we call it here, or the positive remodeling. So these are my take-home messages from this. DCB have been tested in various indications, as I showed you, in-stent restenosis, small and large de novo disease, high bleeding risk, bifurcations, and ACS. And there really are a large amount of DCBs around. However, the differ in terms of design, formulations, drugs, and drug doses, and therefore there's no class effect. Every DCB must show its own efficacy and safety. And there's one device that is there for a long time with a large amount of data, and all new devices should compare with this device to show the same efficacy profile. Thank you very much.
That was a great talk, Raban. Do you want to do questions as we go along, or should we just leave them all to the end? You want any questions now? I've got nothing coming up on here yet. I think everybody's too busy eating their lunch currently. Any questions, or should we carry on with the next talk? No, let's go straight on then. Flavio. Yes, please. Thank you.
Thank you, Simon. Thank you to Brown for the invitation to participate. This is my talk. It's a comprehensive management of multivessel disease with drug-coating balloon. Well, I have to say that there is little, if any, evidence on that. So what I will develop with you in the next 8 or 9 minutes, it's just a wishful thinking. It's a reasoning. I want to drive you through some ideas and some concepts, but of course, it is not based on strong evidence. I would start making it clear that there are some indications where the stent should not be put under trial. I mean, in some indications, alternative therapies are not needed. I mean, maybe, but we know that in large vessels, in short lesions, in low syntax score, in OCL fibrotic calcified lesions, metallic stents do perform very well. It doesn't mean that we cannot do better, but I think there is less of a need compared to other situations where DES are not optimal. For example, in small vessels, in long lesions, in patients with high syntax score, and this is where we are going to focus, multivessel disease, in bifurcations, absolutely, in CTO and in STEMI patients. So why is that? Because if you analyze the outcome of stenting in young humans at the long term, it's 10 years, but 10 years, it's a long term on the paper, it's not a long term in our lives, because 10 years for the middle-aged patient is the minimum we expect to have. You see that after 10 years, more than 50% of patients, regardless the kind of drug-eluting stent, either with bioabsorbable polymer, with permanent polymer, they have a recurrence. So 1 out of 2 of our patients will be back to the lab or to the surgical facility in 10 years. This applies also to new generation drug-eluting stents. You see these are everolimus and sotarolimous loading stents. The same thing observed by other groups, 40% of these patients coming back in 10 years. If we add some other comorbidities, like for instance diabetes, which is very frequent and it's getting really a pandemic in some areas of the world, the recurrence becomes twice more frequent. So there is, for sure, a need to improve the long-term outcome. And this is not being obtained using stents as we conceive them. So I like this. It's, again, a conceptual slide. If we put on the right side, on the left side of the screen, what for years many colleagues have been doing, which is perfect image at the end of the procedure at the price of long stenting and full metallized. This creates absolutely a problem at the long term and provides no option for future interventions. In the other side of this spectrum is what I call the bio-PCI. It's very unfashioned to talk about bios. It's a stentless, metal-less procedures. And in the middle, of course, is the reasonable stenting, is one of these indications I show you in slide number 1, where those stents perform well. So what is bio-PCI? For me, it means be good to the patient. And to be good to the patient, we should keep the procedure simple, use low contrast, we have to be good to the artery, prepare the lesion, and use little metal. I state for an intervention without permanent foreign bodies, ideally, and it's optimal medical therapy. The effects of medical therapy are getting incredibly good and a healthy lifestyle, because it's useless to have perfect corners if you are not in shape. So this is an example of what I want to mean. It's a relatively young male. So you see, 10 years, I mean, if you are 77, it's not that you are too old, but it's very likely that you will come back to the lab. So this is a limit, especially when you have 3 vessels disease, like in this case, you see long lesion, very diffuse disease, totally occluded LAD. And so this is a case of multivessel disease where we need to improve what we have been doing for years. So in this case, to stay with the philosophy of not leaving metal behind, these patients got a bioresorbable scaffold in the opening of the LAD, and this is the final result with a very simple technique. Physiologically, it did quite well. There is diffuse disease, so the QFR is 91, it's not 1. And then it's more challenging to fix this diffuse disease of the artery that after preparation receives paclitaxel eluting balloon in the distal and in the mid part for a quite long 6 centimeters of DCB and a short bioresorbable stent. So this is even better under a physiological point of view. You get a good recovering of the physiology, and this is 1 year follow-up with total resorption of the BRS and healing of the distal dissections and a good residual lumen on this diffusely diseased right, and an acceptable result with no residual struts of the magnesium bioresorbable scaffold in the mid-LAD. So I anticipated there is a little bit of a science behind this. It's a wishful thinking, and this is one of the most attractive papers I have found that compares, it's not randomized, it's a registry derived from a large population that matched 2 groups of patients, 500 patients, half of them treated only with drug-eluting stents of latest generation, and another one with a hybrid therapy that included 35.8% of stents, and all the rest was left to drug coating balloons. So you see, seems to be the same patient. It's not. On the right side, you have 2 drug-eluting stents. On the left, you have 1 stent and DCB. The population is quite young, so we hope to see them back in the next 10 years. And hopefully, what we know is that the group with 2 stents will be 1 out of 2 will come back. We don't know what is happening with the alternative. You see that DCB-only treatment was performed in 34%. The rest was a combination of DCB and stents. The more lesions we have, the more the operators implanted stents. So we go back to the problem, the issue of multivessel disease. When there are only 2 lesions, 72% can be managed only with DCB without metal. When there is 3 lesions, only 60%. When there are 4 lesions, nearly 60% can be treated with DCB. The rest need stents. But the difference comes out at only 2 years. You see the survival curve of these 2 groups. It's impressive. Those getting the stents do have much more events than those having less metal. In terms of global MACEs, 11 compared to 4%, and this impacts cardiac mortality, myocardial infarction, and target vessel revascularization. So the concept seems to be true, and so I would wrap up my presentation, again, not based on strong science, but just on wishful thinking. This is absolutely true. The first sentence has no doubt. More stents we implant, more events we cause. Longer the stents, more events. Smaller the stents, more events. This has been shown several times. Just go back to the Syntax trial that was the first one implanting first-generation drug-eluting stents in multivessel disease, and there is a linear relationship in between diameter, length of the metal, and the incidence of stents. DCB can be an alternative to DS in lesion subsets where DS still yields suboptimal results. Wishful thinking, we need data, and of course patients with multivessel disease are those, as shown in this simple registry performed that I showed you before. Multivessel, they do receive more metal, so a comprehensive management with the addition of DCB may prove beneficial. Thank you.
Are there any questions from the floor? Yes?
Well, I can answer what is our experience in our center. In this study, there was a matching, so there is absolutely a bias of selection, so we cannot say. What this paper shows is that nearly 60 to 70% of patients can be treated with at least one DCB. When we treat patients with DCB and we implant a stent, the main reasons are basically two. The first one is that most operators became concerned on the aspect of the dissection. So we think, and we may discuss this later, that a stent is safer than a dissection, and this is an open question. And the other one is that the balloon-based technology is not enough to yield a good lesion preparation and a final good result. So if you work hard with your devices, either balloons, rotation, or whatever it is, but you still have a 40–50% residual stenosis, we know that the results of DCB will not be good. So in these cases, probably it's worthy to implant a stent, provided that you will be able to expand the stent, because if you leave a 40% stenosis in the stent, it will be even worse. So it's immediate results and dissections. And on the basis of that, we are very liberal with the use of DCB, and we limit the use of stents as much as possible. I think that in more than 80% we manage without the stents. At least, yeah, 20% in a center that is managing many patients with DCB. I think that it might be even more in other centers.
Yes, go to the microphone, please. Or you have to speak very, very loud.
The scaffold, it's the only one that is available in Europe as far as I know, which is the former McMaris, that now it's called
Freesolve.
Freesolve, yeah?
Yeah.
Yeah, by Biotronic.
I have a question to you. You talked about lifestyle management of coronary artery disease. What is your opinion about on treating plaques with DCB? There are some studies here that you might treat coronary plaques, evolving plaques with anti-proliferative medicaments based in a DCB setting.
You mean non-culprit lesions and non-flow limiting?
Yes.
I mean preventive?
Yes.
Ah, well. Plaque sealing. I mean, it's an old concept.
Yeah, before
sealing.
It was plaque sealing.
It was with bare metal stent, with DCB, with bioabsorbent.
I think you don't like it.
No, I think medical therapy is doing so well that it will be difficult to prove that any intervention on asymptomatic, no-flow limiting, non-culprit lesions might do better than medical therapy. I mean, medical therapy has done much more progress than interventional therapy.
Okay, good. Okay, we move on to the next topic. Simon will speak about simplifying bifurcation lesions using drug-coated balloons.
Fantastic, thank you. Thank you for the invitation. Thank you everybody for giving up your lunchtime to come and listen to us talk. Hopefully we can be of some valuable education for you. So, my name's Simon Ecclesall. I work at the Norfolk and Norwich University Hospital in the UK. We've been using DCBs like the other people on the panel for about 15 years. And I'm going to talk to you about simplifying bifurcations. So I'm also going to talk to you a little bit about the checklist, which we sort of touched on just now from the point of view of what's a good enough result. The checklist that we use in our cath lab is along 3 parts. How to do your lesion prep, the safety from the point of view of the patient, and the angiogram, and then making sure that you're using the right sort of DCB. This will pop up a few times throughout the talk. So how does DCB fit into bifurcation angioplasty? You have some decisions to make. The first one is, do you still want to stent the main branch? And the second one is, do you want to do the main branch and the side branch, or is this just a one lesion, in old money, a one stent strategy that you're thinking about? When you've looked at those, this is then where you get to from the point of view of how to do angioplasty, particularly with building in DCB somewhere along the lines. There are 5 basic ways that you can do it. The top 2 are in the setting of a stent. The bottom 3, which I'd prefer you did, are no stents. It's all about DCB. So for a previous talk, I'd actually planned out how you do all the steps in all of these. I'm not going to show you that because we'd be here a little while. But this is the slide sorter from that talk. The top one is what happens when you're bailing out for a side branch. The second one is when you're doing a planned hybrid, so you're DCBing the side branch first and then stenting. Guess what? The three at the bottom are all the different ways you can do bifurcation angioplasty with DCB only, and they are considerably shorter and therefore simpler. So here's a case. There's somebody in the room who did this case with me, or probably did it while I watched, to be honest. A 67-year-old patient with an ACS, diabetic, hypertensive, transient ST changes and raised troponin. It's one of you two there, yes. Stand up when you know which one it is. The angiogram showed a normal right coronary artery, a tight mid-LAD, and the culprit lesion, which was the ostium of the circ. They now know which of the two of them did this case. Here's the mid-LAD. We'll come back to that in a while. Here's the slightly more complicated thing, the bifurcation. Is it one or two bifurcations? So I'll leave that running for a couple of rounds so that you can all decide what you think. So not straightforward, is it? So here's what I was thinking. The culprit is obviously the ostial circ. It's a true 001 bifurcation, which has the worst documented outcome of any bifurcation PCI. Distal left main stem isn't normal. If you image it, it will be distinctly less normal, but it's not flow limiting. The ostial and proximal LAD are not normal, but they're not flow limiting. And you've got a very short, very tight ostial circ with reduced flow, and almost instantly an obtuse marginal branch, again, that appears to have a tight lesion in it. So in the old days, when I used to stent everything, I would look at that picture and I'd try and work out how I can fit my stents in to make it look normal. You don't need to play that game anymore if you're not stenting. So the plan, as always, keep it simple. What we want to do is treat the ostium of the circumflex, protect the obtuse marginal branch, and after a beautiful paper from Prof. Shin a few years ago showing that if you DCB the main branch of a bifurcation, the side branch will get late lumen gain later, we were not planning to treat the obtuse marginal branch unless it went down and started hurting. We're going to use a scoring balloon, 1-to-1 balloon to artery ratio, because that will give you the best lumen gain, the lowest chance of a vessel-threatening dissection. And if we do all of those things, we should be able to DCB it, and we'll run the checklist through the cases we're doing it. So, 3 wires. 1, because the guide would not stay out of the distal left main, so we've wired the LAD to back it off, and also there's a lesion that needs treating. We've wired the OM, we've wired the distal circ, we're only working on the distal circumflex wire at the moment. We've taken an NSC alpha. Scoring 1 is me at the low pressures that we like using normally, 6 atmospheres. You can see that that balloon's a little bit underdone, so we've wound the pressure up a bit more. That balloon now looks like it's fully expanded. So what do? You take a picture. You run the checklist. Now I think everybody in the room would say, don't leave that. That's a really tight circumflex still. Okay, so we didn't. We have a safe result. We haven't wrecked the vessel. But despite the balloon fully expanding, the ostium of the circ has recoiled quite a lot. Bifurcations, they always recoil more. Another reason for using a cutting or scoring balloon. So what do you do next? We'd go back with the same balloon, repeated inflations, higher pressure, longer time, maybe even turn the balloon so that you're changing your scoring planes until you get the result that you're looking for. So high pressure, longer inflations, a few inflations on the left, as you can see. The second one, maybe the balloon's a little bit better expanded and a bit bigger. Take a good angiogram, run the checklist. I would say that now looks pretty good. So we don't have any flow limiting dissection. We don't have much by way of recoil. There's no contrast hanging up in the vessel. There's TIMI-3 flow. The patient is fine. So we've run through all of those things. So generally, by the time you get to the bottom of that lot, it's called DCB time. The DCB has to be very gentle, a nice slow inflation, just to deliver the drug, not doing more angioplasty, and then you run the checklist again. So there's the DCB, a little bit longer than the lesion preparation balloons that we've used. Taken another picture, run our checklist again. We're feeling quite pleased with that. What are we going to do now? Well, we may as well do that LAD while we're there. This is an ACS patient and it looks tight. So we're going to fix the LAD. So I work in the NHS, we have no money. The LAD was about a 2.5 vessel, so we used the same 2.5 NSE alpha. Same thing again, really good angiogram, lots of nitrates, keep running the checklist in the background. So there's the lesion I showed you earlier. We've got the NSE alpha, 6 atmospheres only, 1 inflation, taken the balloon out, and it looks like that. Probably got time to do this. Hands up who would stent that? Who would DCB that? Oh, not many hands. Thanks, Tash, you did it. So this is the acute result. We run that checklist, and the checklist says that we've done a good angioplasty. We have a non-vessel threatening, a safe dissection. We have TIMI3 flow, so DCB time. There's the balloon, slightly longer than the NSE alpha. There's the acute result. You run the checklist again at this point because you want to make sure you haven't made it worse. It's very rare that it's worse after your DCB if all you're doing is a gentle inflation to deliver the drug. It does happen occasionally. So the conclusion of that case is it's a simple solution to what was quite a complex case, because you could have ended up ballooning all sorts of vessels there. We've literally treated one. So it simplifies the patient for us, but here, most importantly, it simplifies the lesion, and a little bit of an add-on at the end that you can see from that LAD dissection. It's safe to leave them, and you get the lowest TLR rates with those sorts of angiographic dissections. So this is what I showed you at the beginning about how to incorporate DCB into your bifurcation practice. The vast majority of what we do now is the simple, short main branch only, relying on that osteal side branch gain. And if you apply the checklist and these sorts of rules, then you can turn these sorts of cases. This is a 40-year-old with that osteal LAD and distal left main. There's the acute result. 3 months later, it looked like that. So even in vessels that size, if you're doing pretty good angioplasty, you're getting late lumen gain. You could also do these. This is an 87-year-old lady that was never going to have surgery. About an hour and a half later, she had a good angiographic result. Thanks very much.
Excellent, Simon. Thank you very much. I think the main topic today is that we want to show you that PCI with DCB is simplifying things. Just think about this main stem intervention with a balloon. If no balloon would have been used, we would face a culotte in the main stem with a second bifurcation down in the RCX. So it would be quite complicated. I think, Simon, the main problem is that we should just have confidence that the result in the coronary vessels, they stay as they are. For example, the LAD was not a no dissection. There was a quite ugly dissection with some contrast medium hanging up.
I would call that a beautiful dissection.
Yeah. But it's important to realize that dissections are good, because with dissections you modify the vessel and the drug is able to enter the vessel wall, and so sure. This is the mode of action of the DCBs.
And I think the important thing is, even if you don't see it on an angiogram, you're always dissecting vessels when you do angioplasty. But actually, if you control the way that you do your lesion prep and maybe use a lot of longitudinal cutting or scoring balloons, the dissections you're going to create are longitudinal dissections, and you're going to end up with non-vessel threatening dissections, as in safe ones, the vast majority of the time. And that really bumps up how often you can DCB rather than stent.
Are there any questions from the floor? So, in the sake of time, I think we... Yes, there is a question.
No, it's you.
But I think we were
there's a load come on here while I was standing up.
I think you have a lot of experience using DCB in your patients. It would be nice. I mean, so far what Simon showed is exactly what the colleague asked. I mean, when to leave it or not. And we discussed about the dissection and the final result of the lesion preparation. Do you have any advice to our colleagues on how to deal with those three things? To leave it without stents?
And if we see some dissection, and like the Simon's case, we usually hesitated to do the DCB. Usually just put a stent. However, an angioplasty means that is a make dissection. So without dissection, and we don't achieve the adequate lumen area. So we need dissection. However, after make the dissection and the flow is normal and vessel enhancement is just rapidly disappear, that's okay. I think we don't hesitate to do the DCB, even that is the dissection type C.
Is there any dissection type you don't leave in your experience? Is there what are dissections you don't like and should intervene on? No, Professor Shin.
Very, very important.
Flow.
Yeah, right. Flow limiting dissection is we have two options. One is just put the stent, and the other one is again and repeat and lesion preparation with the scoring balloon. So slightly upsizing and usually we can resolve the some dissection
And what is your opinion on physiological measurements, FFR, in these dissections? You rely on that?
Yeah, in my early period, I usually check the FFR after lesion preparation. However, and recently I just angiographic flow status is just enough. And in my lecture, I can show some lesion preparation.
You mentioned scoring balloon. I have heard from experts. I have dialogues with colleagues, Simon, Bruno, that the use of scoring or cutting balloons might improve the angiographic image of apparently nasty dissection. And I've never thought about that, but since they told me, I tried to do that, and it's true. Simon, you have a lot of experience. Is there an explanation for that? Do you do that?
So there's lots of reasons why cutting and scoring works really well. We already know that if you do that, you get better acute lumen gain. And better acute lumen gain for us means you're more likely to use a DCB. The second one is, I think because you've got these longitudinal cuts or scoring planes, those are your dissection planes. So if you've just cut or scored all the way down the vessel longitudinally, everything that you've created, because you have to create a dissection, is by definition still in continuity with the true lumen, which is why we always talk about, does the contrast hang up or not? Because if the contrast is in a dissection plane like I showed you there, and it clears at the same rate, then everything is fenestrated and all you're seeing are these intimal tears. The last one is, if you're unlucky enough to have created one of those very nasty dissections with a lot of intramural hematoma and a lot of luminal compromise.
You put a stent.
No. You cut it open. You cut or score it again if you haven't already used such a device, and sometimes even the first time the device will cause something that with repeated inflations will go away. So that would be dissection modification.
I think this is one of the main points that we can share because of our experience. This dissection that looks bad, I have understood your message. I mean, it's like having a parachute where the blood is going and staying there. If you cut this parachute in tiers with the scoring on the cutting balloon, the flow will go easier. And this is what happens even after nasty angiographic dissections with the balloon. You cut all this, then you give your long, low pressure balloon inflation with the DCB that has a carrier, and the carrier helps to heal this dissection, and in the end, it comes to be much better than you expect. But of course, to do that, you have to be patient, DCB time, and refrain yourself to put the stent, because otherwise, there is no chance.
Shall we continue? Question? Very.
That's a very good question, and there are lots of different ways of answering that depending on what paper you want to read. There's a paper that I've seen recently, you may have heard about it, called the cuttering technique, which I think is probably, for me, would be the last resort of how to do dissection modification. So they're downsizing with a cutting balloon in the setting of a large intramural hematoma, inflating it in the vessel, and then literally pulling it up and down whilst the balloon is inflated. Yes. From the look on your face, that's the same as my response, which was, gosh, okay. What we tend to do is just the same 1-to-1 balloon-to-artery ratio with the cutting or scoring balloon that we already have or that we then pick off the shelf. But one of the important things is that you have to go all the way across the lesion, so that you have to allow out at every point, particularly at the bottom end, because what's happening is the intramural hematoma is tracking down the vessel and it needs to get back into the true lumen, or else it will just carry on expanding. Oh, but sorry, one last thing. Before we had any of these techniques, when they got vessel-threatening dissections decades ago with a balloon that was possibly the right size for the vessel, rather counterintuitively, what they discovered works was putting in a bigger balloon. And I think by putting in a bigger balloon, what you're doing is you're creating more dissections, and sometimes you will be lucky enough that you've fenestrated it back to a safe dissection. Raban.
Okay, we move on. Now it's not DCB time in a strict sense, it's diabetic time. You all are familiar with diabetic patients. It's a large clinical problem how to treat them, and I want just to discuss the role of DCB in these patients. We know that stents have some problem zones. This is the data of 25,000 patients from 19 RCTs, and you see here in blue BMS data. This is outdated, of course, but in red the drug-eluting stent generation 1 and drug-eluting stent generation 2 in black. And all of these, they have, after 1 year, have similar event rates. And these event rates are about 2% per year without a plateau. And there's a problem when we implant metallic devices into coronary vessels. So we have to say that ES have some limitation in certain clinical and anatomic conditions. What are these conditions? There are some lesion characteristics stents don't like instant restenosis, small vessels, bifurcations, long lesions, and diffuse disease. But also there are some patient characteristics which are a problem, like diabetes mellitus, ACS, and high bleeding risk. And now we want to focus on diabetes mellitus. This is really old data from a drug-eluting stent that is not existing anymore. This is the Taxus stent. I know this is really old data, but what you see here very nicely is that diabetics have much higher event rates. The black pillars, they are the BMS, and the white pillars are the DES patients, and you see here that diabetes and insulino-dependent diabetes have higher event rates. And so in those patients, the drug-eluting stents don't work that well, and lots of patients get CABG instead. So what makes diabetes a problem? There is an endothelial dysfunction, there is an increased platelet activation, and also there are changes in plaque character with a greater amount of lipid-rich atheroma and an increased activation of macrophages, so that you have a more aggressive coronary artery disease. And if you imagine you implant a stent with the struts, you get this, you get an inhomogeneous drug distribution on the top here of this cartoon. But if you use a drug-coated balloon, you get a more homogeneous distribution of the drug. And this is intuitive that this might work better than stents. There is data on this. There are some randomized controlled trials in de novo disease, and you see here a subgroup analysis from the BELLO trial. BELLO was a trial in small vessel disease, and you see here if you have diabetics, the rate of restenosis is much lower if you treat them with drug-coated balloons instead of the paclitaxel-eluting stent. Of course, this is the old stent I showed you, but here you have a different action and a much better action with the drug-coated balloon. We have data from other stents, from science stents. There have been some Taxus stents in this trial as well, but only a minority. There were science stents mainly used here. This is the subgroup analysis from basket small in diabetic patients. And what you see here is the red curve. This is the bad curve, the diabetics treated with drug-eluting stents. And the lower curves are the better curves. So with DCB, you're able to lower the event rate to the level of non-diabetic patients. This is the message here. And this has been significant in this subgroup analysis. We also looked at the insulin diabetes, insulin-treated diabetic patients. And you see here on this cartoon here, you see the red curve and the blue curve. This is the DS and the DCB in insulino-treated patients. And the green curve and the pink curve, this is the non-insulino diabetic patients. And in both, the DCB was able to lower the event rate. However, because the number of patients was so small, this was not statistically significant. This meta-analysis here is very reassuring. These are randomized controlled data from various or a variety of indications in the field, and you see here always DCB versus DS. And in mortality and also in target lesion revascularization, we have a positive effect of the DCBs here in this setting. However, this is not randomized controlled data for in a larger trial, but at least this is reassuring data. And this comes from Professor Shin's group in South Korea. Again, she did great work all over the place, and in this analysis here, you see that if you lower the amount of stents in a given population, in a diabetic population, then you have a positive effect. This is non-randomized data. However, the results are quite impressive. You see here the diabetic patient with DS in red and the diabetic patients with DCB in a dark blue with a large reduction of events. This is also present in non-diabetic patient, but this result is quite impressive. So even if you're not using only DCB, only you reduce the amount of DS, then you have a really good result here. We talked about the indication for CABG. In diabetics, multivessel disease, CABG is still the treatment number one, and this is, among others, based on this study here, the FREEDOM study from Mike Foucault from 2012 showed that the event rates with DS PCI are higher with CABG than with CABG. These are the first generation DS, the Cypher and Taxa stents, but they didn't perform well. And just if you imagine that in this patients DCB were used, you eventually would have this result, or less DS would be used. And so I think there is hope that at the end, this new treatment, this new DCB treatment we're proposing here eventually helps the patient to get the treatment they deserve and not have to be operated on. So these are my messages. The metallic implants in coronary arteries are associated with an increased event rate, and this is mainly true for diabetic patients. And DCB have in this setting the potential to improve the results. However, the results are limited. We still don't have a randomized controlled trial here, but the data we have are quite reassuring. And we talked about the hypothesis that DCB treatment or a hybrid treatment of DCB and DS might lower the event rates in diabetic patients to the level of CABG or even improve here and make the results of PCI better in this setting. Thank you very much.
Fantastic, Raban. Thank you. I think we need to move straight on to the next talk. We are a little bit behind.
Thank you very much for inviting me. So I'd like to start the one case. And what do you think of this an RCA? It looks good and doesn't seem to need any stent, this kind of an RCA. However, it's not a baseline coronary angiogram. And this is a baseline angiogram. There was a very severe stenosis in the proximal RCA with the poor blood flow. If we had seen this image first, most of us want to put a stent without any hesitation. However, after balloon angioplasty, the stenosis was completely resolved and the flow is normalized. So reassessing the region after balloon angioplasty can help reduce the need for stent. And this is the DCB time. So 6 months after DCB treatment for this region, the vessel had much enlarged and all side branches were completely restored. So the goal of PCI is to improve blood flow by relieving the stenosis. So if balloon angioplasty works, so why do we still need to put the stent? As we all know, the reason we use the stent is to prevent acute vessel closure and to lower the risk of restenosis later on. Now let's go back and look at the data from the balloon angioplasty era. In the Benestant randomized trial, and the rate of in-hospital deaths and myocardial infarction was completely comparable between the stent and balloon angioplasty group. And there was no case of region occlusion within the first month in the balloon angioplasty group. And how about acute myocardial infarction patients? And well, in a study looking at this question, there was no difference in death or MI between metal stent or balloon angioplasty at both 1 month and 6 months. The only advantage with the stent was a low rate of repeat revascularization. In fact, a meta-analysis of over 10,000 AMI patients by pulling data from the multiple randomized controlled trials showed that stent didn't reduce deaths or myocardial infarction compared to balloon angioplasty. In other words, even in acute myocardial infarction patients, routine stenting does not reduce the deaths or myocardial infarction. So stents have come a long way from bare metal stent to drug-eluting stent to reduce restenosis. However, even with DES, the event rate is still about 4 times higher than that of native regions, and it doesn't reduce the natural course even after PCI. What's more concerning situation is that because we leave metal behind, we can't stop antiplatelet therapy, and that means a lifelong risk of bleeding. This bleeding is rare, not common. It's not rare, and it's strongly linked to all-cause mortality and myocardial infarction. So if we can, we should try to relieve stenosis without leaving behind foreign material like metal. So DCB is one treatment option that can relieve coronary stenosis while minimizing metal burden. According to a recent meta-analysis of RCT in small vessel disease, DCB specifically paclitaxel-coated balloons was linked to a low risk of MACE compared to drug-eluting stent, mainly due to low rate of myocardial infarction and target vessel revascularization. So based on this evidence so far, DCB allows us to reduce the metal burden. The approach is very, very simple. First, we perform angioplasty to the best of our ability, then reassess the region. So we just postponed our final device after region preparation. So this is called the provisional strategy. If the region preparation is optimal, we go ahead with DCB. If it's suboptimal, we implant a stent. We have very nice and current generation drug-eluting stent. This stepwise process is well supported by both DCB international guideline and the Asia-Pacific DCB consensus. So what is the optimal outcome of region preparation? If we look back at the balloon angioplasty data, there are two key angiographic criteria linked to hard endpoint, the SMI. First, the flow has to be normal, and second, the residual diameter stenosis is less than 30%. As for dissection, they only matter if they are flow limiting the dissection. Otherwise, the degree of dissection doesn't really matter. So we also have physiologic tools like FFR in terms of outcome. The FFR of 0.75 or higher is acceptable. And if we want to use the surrogate marker, we generally aim to 0.80 or above to call it optimal. So this patient has a 50-year-old man. He had a very long CTO lesion in the middle RCA. After successful wiring with a microcatheter, we found that the lesion extended diffusely all the way to the distal RCA. So first, we performed the balloon angioplasty from the distal to the middle RCA using a 2.5 millimeter non-compliant balloon. Then we upsized to a 3.0 millimeter non-compliant balloon and treated the entire whole RCA region. However, the significant stenosis was still visible at the CTO inlet portion. So we performed another round of angioplasty for this region, but significant stenosis still remained in the CTO inlet portion. So what is the next step? Unlike a conventional PCI, we actually have three options here to reduce the metal burden. First, we can implant a drug-eluting stent at the mid-RCA inlet portion and treat the distal RCA with the drug-coated balloon. And second option is since this was a CTO region to begin with, we might accept this level of residual stenosis and just go with the DCB only for the entire segment. And third option is we can try to further prepare the region by upsizing balloon or using a specialized balloon, scoring balloon and cutting balloon. So all three options are reasonable. It's acceptable. However, we proceeded with further angioplasty using a 3.5 millimeter upsizing and scoring balloon, and like this. And the stenosis is completely resolved like this. So this is DCB time. And this long lesion was successfully treated with the 3 DCB sequence please neo, and the result was excellent. And lesions with optimal preparation can be treated with the DCB alone, while DES is reserved for only case with suboptimal result. This DCB-based PCI strategy helps us avoid an unnecessary stent implantation. Even less experienced operator can expect to successfully treat about half portion and 50% of lesion with DCB. And this case was managed with DCB only after region preparation. It was a left main CTO, a very complicated region. We started with 1.5 millimeter balloon angioplasty first, like this. And next, we perform balloon angioplasty using a 2.5 millimeter balloon across the left main LAD and LCX. For the large vessel, we used another one, 3.5 millimeter balloon for angioplasty. And as the flow improved, the vessel gradually enlarged. So I treated the left main LAD, LCX with the 3 drug-coated balloon, paclitaxel coated balloon. At the 6 months follow-up, you can see all vessels have become significantly larger and flow is normalized. It looks normal vessel. Even left main CTO can be treated with DCB only if the region preparation is done properly, like this. So this is a take-home message. DCB should be considered the first-line PCI strategy for all coronary artery disease. In DCB-based PCI approach, drug-eluting stent is just only reserved for region with suboptimal preparation. The DC-based PCI approach has the potential to improve long-term outcome by safely minimizing unnecessary stent implantation. So looking ahead, the next generation bioresorbable scaffold we already developed are expected to complement DCB treatment and support a fully metal-free PCI strategy. Thank you for your attention.
That was an amazing talk. I think we should have closed the symposium on the follow-up angiogram of your left main CTO, and that was just incredible. So we've run over very slightly, but I'd like to thank everybody for coming. I'd like to thank B. Braun for putting it on. Make a note next time, it's got to be longer. So we've discussed an awful lot about the data behind what we're doing. Raiban's taken us through all the data, a lot to do with the diabetes, and then we've heard all sorts of reasons about why we should be reducing the metal burden. I'll leave you with my new favourite acronym, the 5M rule: more metal makes more MACE. Thanks very much.